Okay. Okay. Hello, everyone, and welcome to the GI Committee open meeting. We have a couple of hours of very interesting presentations and updates. Let's get started. I just want to acknowledge a number of people who are involved with this work. A lot of this putting things together was done by Gabby, and I have to acknowledge that. She did much more work than I did. And we also appreciate, and she never complained about that. And we also appreciate Dr. Ryan's support for the committee as an executive officer. The GI committee has a range of expertise ranging from pathology to surgery, as you can see, imaging. We also have community liaisons who really we rely very much on their wisdom regarding studies that we need to open, but also we ask them advice when things are not going as smoothly. So we have a surgical community liaison also on top of on the medical oncologist, but also radiation oncology, and these are the people who are here. We also have patient advocates, as you know. Florence couldn't make it today, but Carol is here. She's sitting somewhere.
In the front.
In the front. Here she is, yeah, Carol. And we also would like to acknowledge Colmar and Rachel. Colmar and Rachel established a DEI subcommittee. This was started, in fact, a year and a half ago. And it has been really very active, and you will hear something about what they're doing. And this morning we also had a presentation about retention and recruitment, because one of the things about SWOG and also the NCTN in general, there's a number of studies that are accruing very slowly. So how do we really improve that? And a discussion happened this morning, which was really very interesting, generated a lot of ideas, things that we have to follow up on. And we'll be asking all of you to help us on that. Certainly, statistics is our core of what we do, and what we need to really come up with those studies and moving them forward. And I'd like to acknowledge Dr. Guthrie and Ms. Colby, who are sitting in the back next to each other. And also our coordinators, and I'd like to acknowledge Aubrey, Christine, Andrea, and also Brian. But as you know, Andrea joined us only 2-3 months ago, and she's been doing a great job. Where's Andrea? Can you stand up so people can see you? If you have any issues, you know who to contact. And okay. And again, we always, this started from the days of the pandemic when our meetings were virtual, and we relied so much on the help of Courtney to organize them. And she continues to do that even to this day, although her work has become a bit lighter because during the pandemic it was much more difficult. So we have a very busy agenda. And we're going to start with the DEI initiatives and what we've been doing through this subcommittee. But we also will go over the NCTN studies and talk about developing concepts that we have within the six subcommittees of SWOG. In fact, you can also say we have 7 subcommittees with the DEI, so quite a busy committee. And again, thank you all for supporting us. And I'd like to invite Dr. Safian and also Colmar to come here so they can do their presentation. They can come both. So one of you can stand here and one of you can take my seat.
Where's the clicker? Is this it? We represent the Diversity, Equity, Inclusion Committee, subcommittee within GI, and these are our updates. So today we have formalized the DEI monthly subcommittee meeting where we have been meeting monthly. We currently have, it looks like it's growing from 8 to 10 people now, made up of mostly medical oncologists, surgical oncologists. So that's a wonderful thing. We've also been engaging with our investigators, the GI committee, as well as have some community engagement. So we are actually helping out with specific protocols at the concept level and bringing it through to the protocol level, making sure that we are addressing some of the blind spots that we may not be addressing, and making sure that does this study have a great burden within the ethnic minority populations. So that's something that's very important to us. We are currently working on the integration of our recruitment and retention form into new concept and protocol, which was discussed this morning and was given a nice review, and we are happy to move forward with that protocol. We're also partnering with the Recruitment and Retention Committee as well as the Veterans Committee. The Veterans Committee seems, within the Veterans Administration, some some real data that we can discuss is that, the Veterans Administration within their particular Navigate study, their particular recruitment and retention of whites is around 72%, 78%, blacks is 22%, and the rest is others. So they really, really heavily have a large ethnic minority population that we could be possibly pulling from. Discussing the active protocol, we have a prospective study that's been proposed, as well as a possible translational study looking back at some of our tissues that we've banked. And then we have a few publications and a few submissions to ASCO GI, as well as recent publication that has gone to the GI ASCO meeting this past June. Do you have any other updates?
No, that's great. I just want to put a plug that we're constantly looking for new people to join us. We're really interested in new ideas, ways that we can better understand, barriers to trial enrollment, and how we can then move forward in terms of active steps. So either email me, Colmar, Andrea has our email addresses. We meet monthly on Fridays, and we'd love to get your participation.
Thank you.
Thank you so much. Thank you so much, Rachel and Colmar. I'm going to want to invite Saima and Zev, or Saima or Zev only, multiple 2x2 design, to talk about the esophagogastric subcommittee. Thank you.
Okay, so just to go over briefly where we are with the esophagogastric subcommittee here. So we are going to go over some of the recent updates, obviously, in the space, some active NCTN studies, a recent concept that was finally approved and starting imminently by Dr. Saeed, and some perioperative ideas that are tentative, pending changes in the space that will be occurring in the next few months. So just as a background, I think full-fledged now we see the incorporation of PD-1 inhibitors in virtually every patient up front. As we all know, both nivolumab and actually pembrolizumab expected shortly to get approval for all patients with metastatic gastric cancer, because the trial's really quite similar in many respects. We've seen over the last year or two changes even in patients who are low CPS scores still getting nivolumab or in the community. So we have to anticipate that that's going to be the new standard for some period of time in a large segment of patients. Just to briefly summarize, because there have been a lot of concepts, and one of the things about esophagogastric cancer is that it's very popular now for industry trials for a number of reasons. Obviously, first being the emergence of immunotherapy, and then also the recognition that it's the most common cancer, of course, in Southeast Asia, and these trials can accrue very quickly. So we are mindful of where we are in that space. The PD-1 inhibitors perioperatively, which we've had a few concepts in development in SWOG, we're keeping in mind three ongoing trials. One is Attraction 5, which was a negative trial for nivolumab in the adjuvant gastric space. The other one is Keynote 585, which was perioperative pembrolizumab and chemotherapy, which on a press release had no improvement in overall survival. We're going to see that data actually a week from today at ESMO. And the Matterhorn trial, which was adding durvalumab to perioperative chemotherapy, to perioperative FLOT, has also a presentation with a path-CR endpoint, but in terms of efficacy endpoints beyond that, it's going to be another year or so before we see enough events. So,
if you don't mind.
Yes, Phil.
So basically, I mean, the 585, no improvement. Matterhorn, press release, great complete pathological response. What is your take on pathological response, survival? How should people here sitting here judge these trials? Is the PCR?
Yeah, so it's a very good question and a
And
topic.
how would they think of future trials? But how would they judge those different studies? One has this one. By the way, Matterhorn had a secondary endpoint at pathological complete response. It wasn't the primary.
Yes, and it met the endpoint of pathological response. So historically in gastric cancer, the paradigm has been if you do neoadjuvant studies and you show an increase in path-CR rate, that translates to an improvement in event-free survival and to some extent overall survival. That's been the paradigm with chemotherapy, and to some extent we follow that paradigm. Now here, this may be a different story, is the suggestion we're starting to see, because in Keynote 585, for example, reports are they also met their endpoint for pathological response rate, but yet didn't meet their endpoint for event-free survival. And again, we'll find out a lot of the details on that next week, but and Matterhorn met its endpoint for path-CR, but we don't know yet if it'll meet its endpoint for event-free survival. So perhaps the old paradigm of response rate pathologically doesn't equate to improvements in long-term survival in gastric cancer. It's still, that may not work with the immunotherapy sort of mentality that we're in now. I don't think it necessarily should dissuade us from looking at other options, such as other targeted therapies beyond checkpoint inhibitors and other things that are now developing, as we'll talk about in a minute. But it is something that we're mindful of. And the big new, obviously, target on the block is Claudin 18.2, which is a unique protein in gastric and to some extent pancreatic cancer, in which there's a drug, zolbetuximab, which is an antibody. And recently, we've seen publications of two large trials. One of them is the Spotlight trial, which was a placebo-controlled trial in newly diagnosed patients, adding zolbetuximab to chemotherapy in Claudin 18.2 positive patients. The study met its endpoint for progression-free survival. Synchronously with that, or a few months later, there was the publication of the GLOW trial, which essentially also showed that there was an improvement in progression-free and overall survival with the addition of zolbetuximab to chemotherapy. These trials, you can see side by side here, had similar results in the impact of the zolbetuximab to either chemotherapy backbone. One used CAPOX, one used FOLFOX. There were different variations in regions of the world. But the point is that the studies met their endpoints. And the impact of that is that there's going to be, probably as early as December, but who knows, an FDA approval of zolbetuximab in newly diagnosed patients who are Claudin positive, and that's going to come with a new companion diagnostic, of course. So that's going to make for a little more challenging. That's about a 30 to 35% group of patients with newly diagnosed metastatic gastric cancer that now could be considered for zolbetuximab. It also has raised all sorts of interesting questions about biomarker overlap and the impact of these drugs versus the impact of PD-1 inhibitors in front line. That's a whole complicated situation right now. So globally, as I mentioned, there's a lot of interest in gastric cancer, and many of us in the room are involved in many of these programs, but there's large programs with randomized phase 3 trials targeting FGFR. There was a recently completed trial of pembrolizumab and vantinib in chemotherapy, which we're waiting the results are. There's trials, all these are industry sponsored, I'll point out, that are combining with secondary immunotherapies like TIGIT, and they're all enrolling now, and events are maybe a year or two away, making the frontline status of newly diagnosed patients with gastric a very moving target. There's no large second-line trials, interestingly, in this space. That's why Anwar's trial is well positioned, as we'll talk about in a moment. And in third line, there is a INTEGRATE trial, which is a large randomized trial of regorafenib and nivolumab, which is ongoing. Now, in terms of NCTN open trials, here's the 4 that are open at this time. We'll go over these one by one, but there's a perioperative trial with Jennifer Eads, a neoadjuvant question of different radiation protocols by Steve Lin. Natalia Uboa has a study in oligometastatic disease. You can see the accrual on their right. Some are doing quite well, some are just started, and we'll have to see. So the first one is Jennifer Eads' study, which I think is very timely because it asks an important question of, beyond carbotaxol and surgery and adjuvant nivolumab, can you add secondary immunotherapy to that, or I should say combination immunotherapy? Can you add IPI to Nivo and have that impact? That study's now on hold while they analyze the results. It was, I think, very timely in that it accrued just as Nivo was being approved and used. So we'll see the results maybe in a year or so, maybe less, to see if the improvement of ipilimumab to nivolumab was meaningful for disease-free and overall survival. And that could, in many ways, be an important trial also and trigger other interesting combinations in the adjuvant space. The NRG GI-006 trial is a phase 3 trial comparing proton radiation versus IMRT, standard radiation, and that's for the treatment of esophageal cancer. The SWOG champion is David Jen, who's here, and asking the question of 2 different radiation modalities along looking at overall survival. Natalia Uboa and the SWOG champion David Horowitz, who I also saw here, is looking at the role of consolidation radiation in patients with oligometastatic disease, asking the question of consolidated radiation versus continuing chemotherapy in that space. And that study is just starting out, so hasn't enrolled that many patients yet, but hopefully will start to pick up. It's not the most common group, oligometastatic disease, but there is a number of patients, so hopefully that will enroll. And finally, Hae-Sung Park and Paul Oberstein, who's a SWOG champion for this trial, is asking the question of more intense chemotherapy up front. So very simple, straightforward question of FOLFIRINOX or FOLFOX with Nivo, or FOLFIRINOX with Nivo versus FOLFOX with Nivo in newly diagnosed patients. So this is the only newly diagnosed frontline patients going on the NCTN, and that trial just started, and I think that will be a relatively simple trial to enroll to as well. Now, in terms of what's coming, there is a concept that's been approved by Lakshmi Rakshev, which is looking at MSI-high gastric cancer in resectable patients, looking at the role of either immunotherapy alone or chemoimmunotherapy. That trial has been approved and is making its way towards execution. Our own Anwar Saeed and Paul Oberstein have this trial, which I think is very timely, asking in a very, as I mentioned, a space that has no competing trials, second-line metastatic gastric cancer, asking questions about the role of Nivo in combination with Pac-Ram in patients that progress on Nivo. So again, a phase 2/3 study that will be hopefully executed by the end of 2023. I think that's what Anwar told us today, so we'll hold her to that. And so Pac-Ram Nivo versus Pac-Ram, and that's actually, as I mentioned, I think going to be a great addition and will be relatively easy to enroll to. And future developments that we have of interest, as I mentioned, we are still working on perioperative concepts that are incorporating ctDNA, that are asking questions about de-escalation strategies. There's some perioperative novel therapeutic ideas that people are still working on. Those are challenging now, as I mentioned, all the industry competition. We are soliciting and looking for ideas in refractory disease, where we have a lot of patients now who are probably much more common than ever before, have this third-line patient population that exists and has an adequate performance status. And we'll be talking about some novel agents and try to look for a space there to develop new concepts, which is a huge unmet need in this disease. So I will thank you very much for your attention.
Thank you. Thank you. Any questions? Can we just wait for a second if you have any people have any questions or comments for the upper GI? If not, thank you.
Thank you so much, Zev. I would like to invite Marwan, Seth, Phil, all of the above, one of them, anybody who'd like to take the torch forward.
Will you need Seth to present also, or you fine?
I'm just going to present the updates. I think Phil's going to take it from there.
Okay.
That's it. All right, great. So I'm going to present for a couple of minutes the updates, and Phil and Sep will be taking it from there. So recent highlights. I thought I'd just present some of the highlights that from ASCO and how it may impact the field. I think one of the interesting studies was the Atezo tribe, which is basically a real look at the data from FOLFOXIRI-Bev plus or minus Atezo, and looking specifically at PD-L1 expression on lymphocytes and assessing kind of a modified immunoscore kind of biomarker. And interestingly, the high immunoscore biomarker was associated with improvement in progression-free survival, specifically here 21.2 months in those who got immunotherapy within that biomarker positive group for median progression-free survival versus 9.1 months only for the patients with chemotherapy only. And this is leading to a phase 3 trial that is being performed in Europe to see if this biomarker can identify those patients who benefit from PD-1. And this is along the theme of looking at who are the patients who would benefit from immunotherapy within the MSS population. So it does not appear that immunotherapy is dead yet in that group of patients, and hopefully this will shed some light. Second is the study that was presented by Raghav, and that's the Destiny CRC02. And this study looked at 2 doses of deruxtecan, 5.4 milligram versus 6.4 milligram. And I think it shows that 5.4 milligram is as good, so that's good for our patients. I think that's the standard dose right now. It's not an FDA-approved indication or dose at 5.4 milligram, but clearly from that study, it's safer and was associated with less toxicity and activity in patients who were HER2 amplified and RAS mutant. Now, the one thing about this study is that it did not describe the median PFS in the RAS mutant population. It's only 14 patients who were RAS mutant, HER2 amplified, but they had an overall response rate of 28%. But this is the only HER2 targeting agent that is associated with benefit in the RAS mutant population. And that's a space that should still be open for evaluation. We also know we have the HER2 mutation in CRC that is also not being addressed, and that's about 2% of the population.
But you're not surprised that it works in KRAS mutation, right?
Well, since it's an antibody drug conjugate, it's not surprising, no. But still, I think knowing what's the PFS in that population and are there other mechanisms of resistance or less activity in that group would be nice to know. 14 patients is a very small sample size. And along the concepts of locally advanced colorectal cancer is also the integration of chemotherapy preoperatively, neoadjuvant treatment. So a study of about 250 patients with T3, T4 colon cancer were randomized to receiving oxaliplatin-based neoadjuvant therapy followed by surgery or surgery up front. I think disappointingly no difference in DFS or OS, but again, there's less toxicity with neoadjuvant therapy, more laparoscopic surgery in that group, less ileus, less anastomotic leaks. I think the difference between this and Foxtrot is probably not as advanced from the N2 disease perspective, and it's a little bit underpowered. So still a very important area, and the work that Smitha is going to be doing in that area would be really very important. Finally, I think the ESMO GI has been interesting in that it added additional information about the importance of liver metastases and MCRC that are microsatellite stable. This is the LEAP-17 trial, a very large study, 480 patients, was stratified to look at liver versus non-liver metastases. Disappointingly, median overall survival 9.8 months versus 9.1 months. But if you look at the hazard ratio for non-liver, it was 0.65. The p-value for the overall population is 0.0214 for significance, and even though you have a p-value of 0.39, this was a negative study for the overall population. But it does show that there is definitely some improvement in the patients without liver metastases. Again, the PFS here is encouraging, 3.8 months in the overall population. If you look at the overall response rate, 10.4 months for the lenvatinib pembro versus 1.7% for the control arm of Lonsurf or regorafenib, but the overall response in non-liver is 17.7%. Disease control rate was slightly better for the experimental arm. So negative study, but again, tells us that colorectal cancer is heterogeneous as far as response to immunotherapy within the MSS population, and I think there's significant room here for investigation within the MSS group. So Phil will be next. Thank you.
Thank you.
Is this the clicker?
Yeah, just this one goes, and then this is back.
Got it. Thank you.
Don't touch this one or this one.
Understood. Good afternoon. We're going to review the active SWOG and NCTN studies together, and then briefly go over some recently closed studies. The first open trial is the PI, Dr. Van Morris. This is our 2107, which is metastatic disease harboring BRAF V600E, and patients are randomized to encorafenib and cetuximab with nivolumab versus the standard of care encorafenib and cetuximab alone. The study is accruing pretty well, 2 to 3 patients a month, and is currently is nearly half accrued. So we're making good progress on that. And here you can see how the accrual is going. 1922, this is the second line refractory small bowel adenocarcinoma study that Dr. Overman's the PI for. And that trial has been amended a bit to decrease the sample size, change the stats around, so it's about 60% accrued. And patients are randomly assigned 1-to-1 between FOLFIRI being the standard of care and ramucirumab and paclitaxel as an experimental arm, with all patients having received oxaliplatin-based treatment in the first-line setting. Dr. Overman is also the SWOG PI for the COMMIT trial. This is the phase 3 study of FOLFOX and Avastin with or without atezo in patients with metastatic disease with deficient mismatch repair. And this trial is moving along and is about 78% enrolled and will hopefully be finished in the near future. There have been some changes regarding liver function.
Can you go back to this trial? Comment, do you think the rate of accrual changed over time? You don't have it here, but do you think is it accruing the same?
It's slow.
Huh?
It's very slow.
Why is it slow?
Well, I think that a lot of folks are just getting these patients immunotherapy in the community because they do so well. It's unclear what the additive advantage of the chemotherapy is going to be, which is the reason we're doing the trial.
Why would you ask people? Do people use, in this situation, combination of IO plus chemo, or they use chemo alone? And if you use
Off study.
off study, of course. Smitha, you're going to say something. Can come to the microphone and tell us.
Off study?
Speak to it because there are people.
Okay, off study using immunotherapy alone, Ipi-Nivo if I want a higher response rate, or otherwise pembrolizumab if not so worried. One could use, of course, chemo and IO, especially because of the number of patients who progress, pembro alone, but I think most of us are using the IO alone.
I don't have a slide showing the trajectory of accrual over the last year, but we can take a look at that.
Okay.
They recently made some inclusion and exclusion criteria changes to make it a little bit simpler. They also simplified the ECG requirement, and they updated the treatment duration. The Circulate trial, Drs. Dasari and Liu. This is now, we're moving on to another intergroup trial. And this one is selecting treatment based on the presence of circulating tumor DNA in high-risk patients. It's going pretty well with 159 patients accrued out of a total of 1,900, and to date, 15 SWOG patients have been enrolled, and it's recently activated. And recently, some amendment changes opening up to stage 2B, 2C, and stage 3 disease, and allowing one round of chemotherapy as you're awaiting the result of the assay. So this is also designed to enhance accrual. The Eraser trial, open across the intergroup, Sep Galami is the SWOG PI. This is an ablative trial where basically patients with a defined number of disease sites would be randomized between standard of care chemotherapy to progression or standard care chemotherapy with targeted therapy, ablation, radiation therapy to all amenable sites of disease. This trial literally just activated. It's opened at 70 sites, looking for nearly 400 enrolled patients, and they have one so far, but that is very fresh.
What do you think of this trial?
Well, the challenge with the trial is that many of us are already doing this, right? We would all consider integration of ablative therapy with chemotherapy as routine in the management of colon cancer. But there's really no objective data one way or the other to say if that's the right thing to do, and that's what this trial is going to try to clarify. But I do think it's important to realize that, if we have a patient with a liver lesion and a lung lesion, we're going to send them for ablative therapy and the chance to render them free of disease because we think that they're going to do the best.
And do you think OS is the right capture on this study?
This has been through so much review and so many iterations that I'm not going to...
I'm asking you.
Yes, I think it's just fine the way it is.
So what did you say?
I'm sorry?
What did you say? You agree with the OS?
Yes, I think that's fine.
Okay, all right. Thank you.
You're welcome. We have an adjuvant BRAF trial. This literally just opened. Smitha is the SWOG PI. And so here, patients with stage 2 high risk or stage 3 BRAF mutated cancer to be randomly assigned between usual therapy and encorafenib and cetuximab. So this is a really important trial. The challenge here is that in the community, not everybody is sequencing early stage patients. So this does require a bit of a paradigm shift in that in your high risk patients, you want to get them sequenced.
So why don't we poll the people?
Who is in a stage, a T4 N0 or a TX any N patient is getting BRAF automatically like you would do mismatch repair proteins. after surgery or before surgery, routinely. Raise your hand if you're looking for earlier stage patients, BRAF, routinely. Okay, so I think you can see that this is going to present some challenges in how we approach patients. Smita.
It's a great point. And so on the study, they will do the testing centrally for free, and you have all the time while your patient is getting adjuvant therapy to, give them the screening consent, get them consented, get this tumor testing done. And I think it makes sense, particularly like in right-sided patients. That's where the money is to find these patients with the BRAF mutation.
So important pearls then, right? So they've already completed the chemotherapy and they're randomized to observation or the encorafenib and cetuximab, central testing, and the pearl here being right-sided patients. Terrific. Thank you, Smita. That just activated, and there's only a couple of patients enrolled. We're going to go very quickly through some recently closed studies. The COBRA trial closed early. The reason for this is under embargo, but that trial is now closed. That was in stage 2 patients using ctDNA results to help select treatment.
So closed early because it did very well, or?
There were some technical problems, and it's under embargo. That's all I can say.
Okay. Okay, since you're standing there, can I ask you a question?
Sure.
So this study used Guardant, am I correct?
That's correct. It used Guardant.
And with your own wisdom, would you use Guardant or Natera?
Well, it used an older version of the Guardant assay. Most folks nowadays in this setting are using Signatera, but the Guardant Reveal assay has been updated.
Okay.
I think that's fair. Fair question. The Atomic trial, this recently closed. SWOG put 68 out of 712 patients with stage 3 disease, randomized between standard care FOLFOX or the addition of atezo in the setting of mismatch repair deficiency. So we'll await a few years for those results. The Solaris trial, first-line metastatic disease, investigator's choice of FOLFOX or FOLFIRI with BEV, and then varying doses of vitamin D. That is also completed. We put 32 out of 445 patients on that trial. Stacy Cohen was the SWOG champion, and Kimmy Eng was the overall study chair. The PACES trial, 0820 congratulations to Jason, who definitely gets the award, the Persistence Award. I think the trial was open for 10 years. Incredible. So through several iterations, it was able to be completed. And in May, it accrued 354 patients, and it passed the single planned futility analysis. So we'll wait and see. And with that, I'm going to turn it up to Dr. Gholami, who's going to go over our concepts and development.
Thank you very much.
All right, we're going to close off the colon session with just a few concepts in development we're excited to report to you about. I am not available for any commentaries. Do not feel this is a safe space for me to speak up, so this is going to be, I apologize. True. We're going to talk about the very first concept that we've already alluded to a couple times, is the preoperative immunotherapy and chemotherapy for colon cancer, the POETIC trial by Dr. Smita Krishnamurthy and Senthal. So this is going to be a colon cancer graft for patients with T3 and plus and T4 lesions that are MMR proficient, that will essentially be randomized 1-to-1 in a perioperative approach using immunotherapy with ipi/nivo versus immunotherapy plus FOLFOX. With regarding looking at the primary endpoint, we'll be looking at tumor response rates on the path response. Secondary endpoints are toxicity and a 2-year DFS. And very interesting, exploratory correlations looking specifically also at ctDNA in the future. And for the analysis, this is planned so far to include patients, about 20 patients per arm. So we're working on sort of the details on the concept, and I'm very excited to finally push this to the finish line. So the second trial is a trial by Dr. Orban Fakih here, a randomized phase 3 trial with regorafenib, ipi-nivo versus Longsurf and bevacizumab in metastatic colorectal patients who do not have liver metastases. So this is based on its own prior publication in patients with non-liver metastatic disease who had regorafenib, ipi-nivo, and showed a really impressive response rate of 36% with a PFS of 5 months and an overall survival of over 22 months. Again, this is with non-liver patients. This is just in comparison, looking to the BOT recent study with a comparison of response rates of about 23% in non-liver met patients. So as you can see, the progression-free survival for those patients who had no liver metastases and the overall survival was significantly better. So based on that, the current study design is RIN versus Longsurf and BEST as a standard of care, and with a primary endpoint of PFS, the secondary endpoint as listed below, and looking at exploratories, including the ctDNA analysis in all patients. The sample size is about 40 patients for this trial. The third trial is a trial that we are working in conjunction with Genentech, looking at the investigation of immune-mediated changes induced by a TIGIT blockade and atezo plus chemotherapy in patients with colorectal liver metastases. So this is a different concept where patients with liver-only metastatic disease who have resectable disease and are intended to go for curative surgical treatment, undergoing basically a peri-operative approach wherein usually we would use standard of care FOLFOX. Here we're having a randomization to 2 arms looking at FOLFOX plus atezo versus FOLFOX and atezo and a TIGIT blockade. These patients, after 3 months of therapy, will then undergo liver resections, and those specimens will then pre and post compared with regards to tumor regression score as the primary analysis, and then secondary analysis, we're going to look at overall response rates, R0 resection rates, safety, and toxicity. And exploratories are really the significant impact here would be to look for a signal of this combination therapy, looking at ctDNA kinetics, as well as the correlation of the path response with the ctDNA analysis. For this study, we're looking at 40 patients, 20 person per arm, and this is again a pilot study looking for a signal, and it's not going to be a direct comparison of the arms. And then last but not least, we're going to have a new high-pick study for patients with high-grade appendiceal carcinoma. This is looking at those patients with, like I said, high-grade appendiceal carcinoma that will essentially undergo two randomizations and approach, looking at a perioperative approach of patients who receive 3 months of FOLFOXIRI preoperatively before their cytoreductive surgery with HIPEC, followed by FOLFOXIRI again, versus upfront surgical cytoreductive surgery with HIPEC, followed by chemotherapy. These are for patients with a PCI of less than 15 score. The primary endpoint for the study is an 18 months PFS, RFS. The secondary endpoints are listed below. And there's a really interesting, also again, correlative analysis planned for this study. The sample size will include about 50 patients. And with that, I will conclude.
Thank you so much.
No, you don't take comments, but I think you can take questions. Right?
Absolutely.
Any questions?
Just
no comments,
no opinions.
but questions or concerns.
Yes.
Does that make sense?
Yeah, absolutely.
Anyone wants to express any concern or any question about the studies that Seb presented? She did a great job. If not, thank you very much.
Thank you.
And now we'll have Dr. Lisa Kachnik discussing the rectoanal subcommittee.
Evening, everybody. On behalf of my partner who's vacationing with his family in France, I'm jealous. So I'll review recent trial results from ASCO, and then the open and soon-to-be open trials, and some gaps so that all of you can consider bringing concepts to us. So I'm sure most everyone here knows about the Prospect trial that was presented at ASCO and got a lot of press. This was from Alliance with Deb Schrag being the primary PI. The motivation was, as a radiation oncologist, I'm sad, but toxicity from pelvic chemoradiation. And this, you have to understand that this trial was developed about 12 years ago, so TNT was just being thought about. So the standard arm was pelvic chemoradiation, surgery, and then adjuvant chemo. And then the study arm was selective chemoradiation. So you started with FOLFOX, kind of the first study in rectal that kind of brought TNT to the stage. And then you restaged with MRI, and those that had good response went to surgery and then adjuvant chemo, but those that had not very good response then got the selective pelvic chemoradiation. Overall, actually, less than 100 patients did end up getting the selective radiation. So these are the characteristics. For the most part, pretty balanced. There were a few more patients of T3 and positive disease in the chemoradiation arm. The primary endpoint was disease-free survival, non-inferiority, and you can see those lines pretty similar, especially at the 5-year point, which was the primary endpoint. Some of the secondaries that I'll show you: freedom from local recurrence, really important for rectal cancer, and you can see the two lines overlap, so that's good. And here's where it got interesting, I think, in the press, that radiation got a pretty bad rap, was in looking at physician-reported and patient-reported toxicities. And I'm not trying to be biased. I think the trial results are great and that the patients have many choices now. But I just was amazed how the press portrayed radiation based on these results. If you look at physician-reported toxicities, it's actually doubled for grade 3 and above in the FOLFOX and selective chemoradiation arm. And I'm not going to go over all the results down below. All except diarrhea were higher in the FOLFOX arm. But things where you think about for patient choices, to me, when I read these results, if you have a violinist, which is what the discussant said at ASCO, that might be a patient you might think about doing the chemoradiation. Although nowadays we bring all the treatment up front. Or if it's a early age female interested in fertility, that might be someone you think about FOLFOX and cross your fingers too. So patient-reported outcomes, if you look at overall, it was really similar between the two groups. And then there were just different toxicities per each arm. During the actual neoadjuvant treatment, the FOLFOX group had less diarrhea and better bowel function. The chemoradiation group had less anxiety, appetite loss, and a bunch of other toxicities. And then at 12 months post-treatment, things were pretty similar to recovery. FOLFOX group experienced less fatigue and neuropathy and better sexual function compared with the chemoradiation group. So I think in conclusion, we have lots of good choices for patients now. Neoadjuvant FOLFOX with only selective use of chemoradiation is one of those options that I think of for intermediate disease. And when I have to say this summer, after an explosion of data, I'm not presenting over the past year and a half, I was in a conundrum at Tumor Board. But from this data set, I look at it as if you have a sort of non-low, so a mid or a high T2 or T3, and you have circumferential margins that look clear in your MRI, I think that's a perfect patient to start with chemo and see if you can omit chemoradiation.
So since this is an educational session,
this is what we were asked to do.
No, I think this is the open committee is educational also. So what is your take regarding the MRI, because you're using the 20% cutoff for response?
Oh, I have to say we all probably haven't even gotten to that point yet in practice. So now I have a few patients getting their chemo, and I think that if they have a good response, you just continue the course without chemoradiation. I'm not sure I'd do a 20%. I think, use common sense.
But outside of the clinical trial where it's open to the community and everyone, do you think the MRI, what is your take on doing the proper MRI? Let's make it this way. Or proper read of the MRI?
I hope that's not my phone. What is my take on doing a proper MRI? Is that what you asked? Where's Sep? Sep, I don't want these comments either. I mean, I think nowadays, and we can take a poll of the room, I think radiologists are really comfortable with MRI staging. So I think if I saw a really, a good response, it's probably okay to proceed. But it's not so simple anymore, and I don't have time to go into it. But nowadays, it could be bimodal therapy, it could be watchful waiting. There's like so many things to consider for each presentation. Maybe that's next time we can go over those. So I think unanswered, as I start to talk about watch and wait, there's so many options now that I think it's what is important to the patient, which might be functional outcomes. And we don't have a trial looking at prospect versus watchful waiting. I'm not sure we'll get to that trial anytime soon. And what about the patient preference? Is it dependent on age? How do we get that data? And would patients themselves be willing to go on a trial of sort of prospect versus watch and wait? So here are our trials right now from the intergroup. The first one is from ECOG, Akron. It's the DECREASE trial. It's looking at early stage localized anal cancer, less than 4 cm node negative. It's randomizing those patients to from 1 to 2, 1 being the standard dose chemoradiation that we use, and then the 2 is de-intensified chemoradiation. The primary endpoint's 2-year disease control, which is really the norm for anal cancer these days for trials, and then also looking at anal rectal patient reported outcomes for function. And it's accruing really well. It'll probably finish in about a year. The next one, also from ECOG Akron. Oops, and I'm sorry, I didn't mention, I was terrible there. I didn't mention our study champion, James Murphy. And then the next one from also ECOG Akron is 2176. This is a phase 3 looking at immune checkpoint inhibition with chemo and treatment-naive metastatic anal cancer patients. Kathy Ings, the PI, and Van Morris, who's here, is our SWOG champion. You can see the randomization here is between carbo and Taxol versus carbo, Taxol, and Nivo, and it's 2 to 1. It's accruing fairly well. We're halfway done, and SWOG is almost up to 20. So thanks and continue your enrollment to this trial. And this is our watchful waiting study, really a labor of love with many of our groups participating. You can see Arvin's really one of the main PIs for the study and our SWOG champion as well. And this is taking both intermediate and high-risk rectal cancer and randomizing it to long course chemoradiation, both arms. The standard arm is then FOLFOX, and then the experimental arm is FOLFIRINOX. Although in essence, we don't really have a standard for watchful waiting. Maybe this will create one. And the primary endpoint is clinical complete response. For our enrollment, this study actually opened probably not even a year ago. And you can see we're almost or at a third done, and SWOG's doing really well. So some updates. So because we're doing well, the NCI is interested in maybe moving to a phase 3 trial. So that's in discussion right now. And also to do watch and waiting, you need meticulous follow-up. So you have to have a patient who is willing to do that. And the watch and wait schedule is going to be changed in the first 2 years from MRIs from 4 to Q6 months and endoscopy every 3 months. We have one trial that'll be opening, partially developed by us in SWOG, and that's for stage 1 rectal cancer. It's called the NEO trial. It's a phase 3 looking at neoadjuvant chemo excision and observation versus chemoradiation therapy for early rectal cancer. Dr. Konecki's the PI, and then Dr. Horowitz and myself are two of actually many rad oncs to do the QA for the radiation in real time. Just to look at the schema, it's clinically T1, T2, and 0 rectal cancer, proficient MMR status, stratified by T-stage and gender, and randomized to what is considered the standard on this arm. On this trial, chemoradiation, and then restaging to look to see if there's a clinical complete response versus chemo, and then restaging. Very similar in terms of the elements to the Janus trial, and I'll show you what I mean in a second. But if you do not have a complete clinical response, you'll end up getting a local surgical procedure, and then if it progresses, you'll end up getting a TME. I think I covered that. The primary endpoint, again, is CCR. There's actually the NCI wanted co-primary endpoint of functional outcomes, which made sense to us. And then the secondary endpoints are listed below. Looking at the stats, the total sample size is 250. And then just to show you how in developing this, we really aligned it to the Janus trial so that there's trials open for organ-sparing therapy in both early stage patients and late, and the primary endpoints are the same. Incomplete responses get surgery, and recurrences on the NEO trial, as I mentioned, get a TME. So where do we have gaps? So we did not present at this meeting, but Dr. Horowitz is working on a stage 2 and 3, a SWOG trial for localized, looking at a checkpoint inhibitor and a LAG-3 targeted agent in neoadjuvant therapy for anal cancer, followed by chemoradiation and 2 more cycles of the same dual therapy. We are in discussions of trials looking at ctDNA or HPV DNA incorporated targeted therapy trials. Refractory disease is a wide open area. And for rectal cancer, you could see that we have early stage and late stage watchful waiting trials, but you could look at still smaller trials interrogating new agents or new agents with radiation, thinking about the next phase 3. We do have, I didn't mention here too, actually, I thought I had a slide on that. On the, that's okay. There's yet another option for patients. So, I mentioned proficient MMR status, but for deficient status or MS instability, you have the immunotherapy as an option. And there is a trial of that as well that I apologize we omitted. That trial actually has chemoradiation on it, but it's also, and surgery, but it's also looking at a watchful waiting approach right now, and it's being revised and sent back to the NCI. We will have a retreat in the spring, so please send any concepts. Really go back and ask your early career investigators if they're interested in joining our group, but also in submitting a concept to discuss at the retreat. Thanks.
Simon. The microphone.
I was going to say, I could repeat your question too if you're lazy. I would be.
I'm lazy and I will get up and go to the mic. Can you comment on the role now in your practice on short course versus long course radiation?
Yeah.
I mean, I feel like things have gotten incredibly complex in terms of
Yep.
Do we radiate, do we not radiate, do we use multimodality therapy, and when do we use short course, long course, and do we do it first or do we do it after?
Yeah, before coming here, I gave a talk on all of this. So before the summer, before the long-term data of Rapido came out, which was a trial looking at bringing short course up front before chemo for stage 2 and 3 disease, that trial actually looked really encouraging. There were a few percent increase in local recurrences in the longer-term data. So the thought was, well, do we use that for watchful waiting? And I have to say, in my practice, I shouldn't say most, but half of the presentations are lower rectal cancers where they're close to the sphincter, and you probably are going to take a watchful waiting approach. So initially, before those Rapido results came out, I'd say short course or long course. But now I've switched back to doing, for these patients, long course chemoradiation, FOLFOX, and then reevaluated. I've given a higher dose, and we use those doses on the Janus and the NEO trial. Instead of 50 gray, it's sort of 54 to 56, so I give 2 extra boosts now. And then we reevaluate and sort of see what happens for organ preservation versus not, although we do put the patients on the Janus trial. And then short course, I reserve it now. I have a patient right now who's wheelchair bound and blind, who I was actually going to do long course, and the family said, well, we can't carry her up the 6 flights of stairs for 27 fractions, so I'll use short course on that patient. I use short course all the time for oligometastatic disease, or if someone lives far away. I've had pretty good results with short course FOLFOX and watchful waiting, so I don't know, I'm less nervous, but I think with the Rapido results, I'm mindful. All right, long-winded, but I hope that I helped.
Lisa, I have a question. Can you remind us all in prospect how many patients treated with FOLFOX needed rescue chemoradiation? Because the relapse-free survival 2% at 5 years looks pretty amazing.
It wasn't many. I forget, it was less than 100. I remember something like somewhere between high 60s or low 80s or something like that. So not many.
That's like 10%.
Yeah. Well, that's why I'm saying most patients will have a response. So I don't know if I'd use a 20% cutoff or if I can even figure that out really on my MRI. But I think if they have a response, it's probably safe to proceed without chemoradiation.
Yeah, that's 10%.
Yeah, 10%.
This was great. Thank you so much.
Okay, so next I'd like to invite Dr. Sohal and Dr. Lawi to tell us about the pancreatic cancer subcommittee. Andy's coming.
Thanks, Philip. This is obviously for Devendra and myself. Devendra couldn't be here. So this is kind of an overview of the current NCTN portfolio. And what you'll see is that we have trials for resectable pancreatic cancer, and I'll go over these in more detail. Two different trials. We don't have anything right now in the borderline resectable space or in the locally advanced unresectable space. There are a few concepts floating out there for the locally advanced space, but this points out opportunities, certainly for concepts. Similarly, there are 2 trials open in the advanced metastatic disease space, which I'll review. But I would say, given the number of patients we have here and the nature of these trials, this is a wide open area still for concepts. And similarly, we have a couple of trials that are going to open, beyond first line. But again, these are really niche trials that don't apply to the majority of our patients. So there's a lot of open space in the pancreas portfolio for investigators, particularly young investigators, to be thinking about. So really encourage concepts, because we want to keep SWOG in a leadership role in the pancreas portfolio. So the first trial to talk about in detail is a trial being led by our own Vincent Chung. It's the randomized phase 2 trial of olaparib and pembro versus olaparib as maintenance therapy in patients with advanced disease and germline BRCA1 or BRCA2 mutations. This is obviously a niche trial, which these are always hard to accrue to. Vincent, I didn't know if you wanted to make any comments. This is the schema, and we're nearly half accrued, but Vincent.
Yeah, no, I just want to thank everyone for your support. We've actually had some ups and downs with this accrual. During the summertime, it looked like everyone went on summer vacation, so we're accruing like 0 to 1 per month. But recently, in the last 3 weeks, we actually accrued 3 patients. So we're about 42 patients right now. We have a futility analysis when we get to 44 patients. So we are making progress, and I just want to thank you for your support. The other thing, too, is that one of the important parts of this study is that when you have a newly diagnosed pancreatic cancer patient, you have to send them for germline testing immediately. And I think that's one of the difficult parts is that you're not sending the germline testing, because we did amend the study to allow 1 month of gemcitabine and nab-paclitaxel chemotherapy while you're waiting for that germline testing to come back. But they have to immediately be switched to a platinum-based chemotherapy. So they have to receive a minimum of 4 months of platinum-based chemotherapy prior to being randomized onto this particular trial.
Thanks, Vincent. This is a really important trial for us to get accrued. There's accumulating data from other groups, retrospective case reports about the value of immunotherapy in this population. So we really want to get it accrued and encourage you to keep it top of mind. The next trial is ECOG 2186. It's being led by Efrat Dotan from Fox Chase, but David Zen is the SWOG champion. This is a study evaluating treatment in older, frail patients with naive metastatic disease, and the schema is before you. This trial is actually nearly accrued, so this is great because this is the first trial of its kind. And we will be getting results, in the next probably year to year and a half, hopefully, post-accrual. So thanks for your support of this. We anticipate this being done certainly before the end of the calendar year. Now we move on to the trials in resectable disease. This is Alliance 21806 being led by Christina Ferroni. Steve Berman is our SWOG champion. And this is a trial asking the question for patients with resectable disease if perioperative FOLFIRINOX is superior to adjuvant FOLFIRINOX, which is the obviously historical standard. This trial has been kind of inching along. It really struggled in the beginning. It's picked up lately. It's more than halfway accrued, but obviously there's still a large number of patients to be accrued. And, we really want to get this study accrued because there are identical studies being run in Europe that started about a year past us. And so we'd really like to finish this before the competition. Again, just to remind you, any pancreatic cancer that's resectable is eligible. It's not just a head-only study, as some have been in the past. So if there are any questions about the study, let Steve or myself know, but please keep this in mind at your institutions.
I recently attended a meeting in Italy, and the speaker, Gavi, said the standard of care is surgery. How do you answer that?
So I think to stick to my NCCN book, there are 2 standards of care. Perioperative chemotherapy is an accepted standard, especially I would argue in patients with high-risk features such as very high 19-9 or equivocal medical condition or equivocal imaging findings, etc. I personally think this study is going to end up being a study of patients who have small tumors, low CA19-9, because I think a lot of us don't have equipoise about enrolling the group I just spoke of. which is fine, and it'll answer that question. But I think that clearly adjuvant FOLFIRINOX is a standard of care. It's certainly the standard that's been better tested in a randomized phase 3 setting, but that's why this study is important, and that's why we really need to enroll on it, because there may be groups of patients who it doesn't matter, or even potentially that upfront surgery is superior. So we don't know the answer, and that's why we need to accrue to this study and get it done. And since it's more than halfway there, we got to keep pushing ahead. The other study that is available for patients with resectable disease is, again, a niche study being co-led by Kim Reese-Binder and our own Anoop Kasi. This is ECOG 2192. It's a randomized, double-blinded study of olaparib or placebo following adjuvant platinum-based chemotherapy for patients who have resected pancreas cancer and who have a pathogenic mutation, which can be somatic or germline, in BRCA1, BRCA2, or PALB2. So again, a study that's only applicable to a small group of patients, which requires really all of the cooperative groups to participate. As expected, the accrual is somewhat slow. It's about a third accrued, but we encourage you to please think of this study and try to enroll to it, because again, applying the POLO data to a group of resectable patients, an important question that we want to get answered. I don't know if Anoop is here.
I didn't see.
No, okay. So the next study to talk about is a study that is being prepared for submission to GI Steering Committee, being led by Devendra Sohal. This is now S2411. We've talked about the study a lot in the previously because it's been in development and gone through multiple iterations. It's going to move forward as a randomized phase 2 study with multiple arms using the control arm of neoadjuvant FOLFIRINOX, and then comparing essentially 2 experimental arms, one targeting the IL-1 pathway and the other targeting CXCR4. These are both, essentially immunomodulatory strategies in combination with FOLFIRINOX. So we're very excited about this study. There was a lot of support in the cooperative group at the task force level, and so we're hoping to get GI Steering Committee approval. This is the exact schema. Again, it's a randomized phase 2 design with 2 control arms, and you can see all the details on the slide. These are the eligibility criteria. One thing to point out, assuming this trial moves forward, it is designed as a trial that will include both resectable and borderline resectable patients, which are not being, there's no trial currently for them in the NCTN portfolio. I'll skip that. This is a study that's being read by Rachel Safian. This was recently endorsed at the task force level and is a randomized phase 2 study of chemotherapy plus panitumumab for second-line treatment of patients with KRAS wild-type pancreatic cancer. So again, a niche group of patients, roughly 5 to 10% of patients. This is an important study for an often overlooked group of patients. I don't know, Rachel, if you want to make any comments about the study.
Just gonna add that I think it's a very important study to do, and one that's based on retrospective data suggesting that KRAS mutation status is predictive of anti-EGFR response, and then of course the data out of the notable study from ASCO 2022. The only other thing I want to add is that it's, as of now, it's tumor-based testing, so really important to send next-generation sequencing at the time of your patient's diagnosed.
Great. And here is the schema. So very simple, straightforward study, which is great, and we're excited to move this through and get it open. So I think I discussed, a lot of the gaps that we have, in the portfolio. There are a lot of exciting developments in the field. Many of you probably saw the Nature paper from Vinod Balachandran and the Memorial Group on the mRNA vaccine using the same technology used to create the COVID vaccine, which was given as an adjuvant after resection for resectable patients. The key notable finding was that patients who had a documented immune response to the vaccine had no recurrences in that group of patients, which is about 50% of the patients, which was markedly different than the patients who did not have an immune response. And one of the questions was that just a marker of immune response itself? But patients were also given the COVID vaccine, and essentially those results didn't track with the COVID vaccine responses. So clearly it seemed specific to the personalized mRNA vaccine. I think everybody's aware of all of the excitement in the field around KRAS targeted drugs, particularly the pan-RAS inhibitors, as well as the KRAS G12D specific, which is the majority of the largest subgroup of our pancreas cancer patients. Those are moving through early phase trials, and our hope is to get our hands on some of those in the context of cooperative group studies. Talked about locally advanced disease. There's going to be a state of the science kind of clinical trials planning meeting planned for next year to really discuss the role of radiation and to develop some radiation focused questions to try to really move us beyond the hand waving about the role of radiation in pancreas cancer, which currently exists. And like I said, lots of room for metastatic disease trials in the portfolio. So I'll stop there and glad to answer any questions.
So can I just ask you, regarding the radiation therapy, where do you see in the locally advanced, in practice, people give 4 or 6 months of chemotherapy and then they do radiation treatment. Mm-hmm. So the state of the science, what is it going to look at? Modality of the ablative versus?
Yeah, I think that, so one of the proposals currently is about ablative radiotherapy, because there is a lot of, single institution data with some impressive, long-term results at, showing extended 3-year survival for high-dose ablative therapy. And so that is one of the concepts, essentially induction chemotherapy, and then a randomization between ablative therapy and kind of a conventional chemoradiation strategy that's been used. Obviously, there are other questions that could be asked, the use of ctDNA as a stratifier. And then, obviously the concept of understanding the tumor biology and whether there are specific signatures that we could exploit to select patients for radiotherapy. Because it's clear, we know from neoadjuvant studies that, that some patients have complete responses when they're given chemoradiation. Outside of, a few mutational subtypes like ATM, ATR, we don't have a good sense of who those patients are. And so I think there's a lot of interesting questions that could direct trials.
Complete response to radiation, that's lymphoma sitting there, right?
No, we see it occasionally in pancreas cancer.
Complete response is, I'm a bit hard pushed to see a complete response unless it's something else. But what is your thought, Andy? You're a deep thinker.
I think that my thought is, again, that it goes back to science, and that if we understand, and I have seen patients have complete responses where chemoradiation was incorporated. Now, obviously, patients got chemotherapy as well, so you don't know, but I think that if we understand, if we can identify signatures that predict response, or drugs that modify the biology of the tumor such that it is more responsive, then it certainly can become useful. I think we clearly have a problem with local recurrence in this local progression, both obviously in the locally advanced space and in patients who have surgery. Local recurrence rates are extremely high, even in patients who have margin negative resections. So the idea of improving local therapy is a valid one. Obviously, we need to improve our controlled metastatic disease, probably even more. But as we do that, the local therapy question becomes, even more important. So I think studying it in locally advanced disease certainly makes the most sense because those patients have declared a biology that's more local in its nature. And so hopefully the trials planning meeting will come up with a few good concepts that we can explore.
I mean, we do have patients in our practices who got radiation after induction chemo and they stay stable for a long time.
Yeah.
I think it's a matter of going back and studying those patients and see what makes them different from the others.
Yeah.
Andy, I have a question for you. We talk more and more about the oligometastatic pancreatic cancer. What's your opinion about patients who have limited metastatic disease treated with maybe a induction chemotherapy? Who are the patients who you would offer local therapies, including surgery, ablation, radiation?
Yeah, well, I'm not a very big fan of surgery for local oligometastatic disease just because I think that, the nature of surgery is that there's more morbidity as well as that it's an immunosuppressive event, frankly, to do an operation. I do think that there's a role for radiotherapy. Certainly we've seen at our institution patients have very durable response to, the question always becomes, what is oligometastatic disease? How do you define it? What time period of stability on systemic therapy, how many lesions, et cetera. I mean, you and I were just at a meeting where, there was some interesting data presented about the radiation therapy to lung metastasis in combination with immunotherapy, where there were complete responses from multiple nodules. So I think there's also differences between, the metastatic sites, the lung and the liver, different. But I think the morbidity of SBRT, for instance, to isolated liver lesions is so low. I mean, patients have almost no toxicity from that. That, to me, it just makes sense because, when their biology tells you, that they're doing well and there's only a single 1 or 2 lesions that are small, I think, you don't lose very much at all in terms of quality of life. I mean, it's really, mostly a cost issue, but I think it's definitely an area to explore. Again, these are people who have different biology, clearly. And so I think when you see unusual biology, you have to think that we should treat it differently. And I think people are doing it more and more. And I think, but we do need to study it, and we do need to have more rigorous definitions, because if, what one person calls oligometastatic disease and control, another, if the definitions are all over the place, then you end up with literature that's impossible to interpret. So.
All right. Any questions for Dr. Lowy? Okay. Andy, thank you very much as always. I think next, I know, but is he? Where is he? Here I have it. So basically, Doctors Strasberg and Desari couldn't make it today, and Dr. Zen kindly agreed to present on behalf of the neuroendocrine subcommittee. Thank you very much.
Of course. All right, well, I have a high bar to fill for Dr. Strasberg and Desari, so I'll try my best here. So,
yeah, actually, that's true. It's a high bar.
Thank you. Next slide. Yep, I think we got it now. Yeah. All right.
I'm sorry, I forgot to put your picture up, Dave.
Oh, it's okay.
But you're in person.
Yes. So we'll start with some of the SWOG-led trials in neuroendocrine. So the first one is a study led by Dr. Suarez and our surgical champions, Dr. Ahmad, and our pathology champions, Dr. Washington. So this is a very critical trial in that in neuroendocrine tumors, we really have no data for the benefit of any adjuvant therapy. Now, with that said, in our highest risk patients, particularly our high risk pancreatic neuroendocrine tumor patients, and also the data from ECOG 2211 demonstrating the benefit of CAPE-10 in pancreatic neuroendocrine tumors. This is evaluating the role of adjuvant CAPE-10 for 4 months versus observation, which is our current standard of care in high-grade pancreatic neuroendocrine tumors. So the bar here is a total of 154 patients with an enrollment of currently of 27. So Dr. Suarez has been doing a lot to try to promote this study. We actually just returned from the North American Neuroendocrine Tumor Society NANETS meeting in Montreal last week, and she did a great job in promoting her study. So I'm going to be her cheerleader for this study here, but she's tried to be as broad as possible with this study. So these are high-risk pancreatic neuroendocrine tumor patients as defined by the Zaidi score, which is the factors that are listed on the right side here. Patients can have limited sites of metastatic disease, mainly in the liver, up to 5 lesions, and Ki-67 also has to be done. There's also some cases where surgeons may use somatostatin analogs to prevent the risk of pancreatic fistulas, so there is an allowance that for limited use in that setting that patients would still be eligible, but not for the primary treatment of the neuroendocrine tumor. Dr. Suarez also wanted to comment that she's made some changes to the study, including that patients can actually receive telehealth visits as part of this study, so physical exam is not required. However, the treatment will still have to be given through whoever the treating physician is. So, so please, if you can consider opening the study, this is a very critical study in the field for which we've been waiting for an answer for quite a while. The next study is a study that I'm leading. This is in the opposite spectrum of higher grade extrapulmonary neuroendocrine carcinomas. This is SWOG 2012. This is a randomized phase 2/3 study of first-line platinum etoposide with or without atezolizumab. Again, this is for all extrapulmonary neuroendocrine carcinoma, so it doesn't matter what the disease site as long as it's outside of the lung. All patients have to have a Ki-67 score of 55% or greater. They do not have to have RECIST measurable disease. They just need to have evaluable disease and a performance set of 0 to 2. We do understand some patients need to get started on treatment sooner, so patients are allowed up to 1 cycle of standard platinum etoposide, and asymptomatic brain metastases are eligible. As you can see here, the 2 experimental arms, which is induction chemoimmunotherapy versus then maintenance atezolizumab, and also chemoimmunotherapy alone followed by observation, are being explored just because we have lack of prospective data of what the benefit of the maintenance portion is. And the primary endpoint here is looking at both the overall survival from the time of randomization and then the secondary endpoint, the overall survival from the time of maintenance, looking at the role of the maintenance treatment. So this study was activated in December 2021 with 189 planned patients. It was very slow to accrual initially just because when the study was conceptualized, the NCI restricted to small cell only, given that it was competing with another NCTN study. But since that NCTN study has closed, we have led to a protocol amendment, and so now we're allowing both all kind of neuroendocrine carcinoma subtypes. And since we've made that amendment, that's actually really helped with accrual. So it started with 3 patients in a year, and now we're in 24. So we're averaging about 2 to 3 patients per month, and we're hoping to keep that momentum. And there are efforts underway to try to improve the accrual to this study. The other study is the NET Retreat study, which was opened in summer of this year. This is a co-lead effort by the CCTG, so the Canadian cooperative groups, along with Aman Chauhan, who's our SWOG co-chair for this study. But this is answering the question of in patients who've received prior Lutathera, there are some patients who might benefit from a limited retreatment of Lutathera. Typically, the patients who get the most benefit are those patients who don't have progression of disease after 12 months from the initial course of PRT. So this is the first prospective study that will be evaluating what the benefit of retreatment with PRT and it's comparing against everolimus. And because the primary endpoint here is PFS, there is crossover allowed if patients are randomized to the everolimus arm.
So this study is accruing?
Yes.
It's open. We don't know how many patients so far?
No, I don't. I think we left that out on
because
the slide.
there may be a competing trial, industry trial of the alpha emitter.
Yep.
So that will be where it may have some competition.
Yeah, and you know, that definitely is a legitimate concern, and a lot of patients may be going on the Action-1 study. We do have to keep in mind that as we think about the longitudinal treatments for neuroendocrine tumors, we also want to keep all treatment options that are available. So Even if a patient gets a retreatment, doesn't mean that a patient can't also get alpha PRT down the road as well too, although that is a current exclusion criteria on the Action 1 study. So it will be a discussion both mutually between the patient and the physician about that. So,
Thanks.
So in terms of other ongoing NCTN trials, I think this is the one that has made the biggest press here. This is a long-awaited study, the Cabinet study run by Alliance, and it's a randomized, double-blinded phase 3 study of cabozantinib versus placebo in previously treated GEP-NET patients. This study, the SWOG champion is Dr. Strasberg, and we're happy to report that there was a press release in August of this year stating that the study actually met its interim analysis, so the study was actually closed early due to positive results. We don't know what magnitude of benefit is. The final results are actually going to be presented at ESMO next week, so we're actually going to be waiting on these results. And I do think this is probably going to change the landscape and probably new ideas in terms of next generation trials for neuroendocrine tumors.
So it's going to change the landscape. How? I mean, it's just going to add another drug for you, right?
It will add another drug, but I think the questions that will be asked is, are there novel combinations that you can think about? We have not answered questions about sequencing of treatments, and there could be other avenues that you could explore there.
And in addition, I think we do have sunitinib for PNETs, which is rarely used, but now we're going to have another anti-VEGF TKI for carcinoids, which we don't have a TKI
That's
right now.
correct, exactly. This is another trial which unfortunately is slow to accrue, but it is a very important one. This is an Alliance trial, which is a phase 2 trial evaluating temozolomide versus temozolomide and niraparib in pheochromocytoma and paraganglioma. So the planned number of patients here is 76, and I think we have 24. The SWOG champion here is Dr. Lopez. Again, a small patient population, but an important study. The next trial, our SWOG champion here is Dr. Handafar. It's led by ECOG, by Drs. Pata and Hope. This is a randomized phase 2 trial of lutetium-177 dotatate versus everolimus in well-differentiated lung neuroendocrine tumors. You can see here the enrollment is very slow. There's been a lot of discussions about this trial, and I think one of the barriers here is that unlike GEP-NET patients, the somatostatin receptor expression is very variable in lung neuroendocrine tumors, and so oftentimes many patients actually are ineligible. So I think about 30% of lung neuroendocrine tumor patients are actually somatostatin receptor positive. So, so that is proving to be a barrier, but nevertheless, people are doing this in the clinic, and I think this is an important question that needs to be answered. The next trial is another Alliance trial. This is a phase 2 randomized prospective trial of lutetium-177 dotatate versus CAPTEM in well-differentiated pancreatic neuroendocrine tumors, led by Dr. Habde, and our SWOG PI is Dr. Suarez. Again, this is really getting to sequencing of treatments. So we have a menu of options for our patients, but we really don't know if doing one treatment over the other first or later improves outcomes. So this is one of the sequencing trials. Again, very slow to enrollment. Primarily, both of these treatments are probably available in the clinic, but nonetheless is something being promoted that hopefully we can get an answer so we can inform our clinical practice.
Do you know how long it was open?
So I believe this was activated at least a year and a half ago, so it's been a little while. So.
Yeah.
And then reviewing non-NCTN related trials, so there's quite a few. I think if I had to broadly just kind of think about it, so Sorrento being is a trial looking at basically a different formulation of octreotide, but at a very higher dose, based on some retrospective data that higher doses of somatostatin analogs might promote more benefit than standard doses, and so that's what Sorrento is. The other trials, NETTER-2, COMPETE, COMPOSE, are evaluating lutetium-177 dotatate in basically higher grade disease. NETTER-2, though, is looking at higher grade disease in the first line setting, and in Action 1, as we talked about, is looking at alpha emitters. There is a press release, though, that NETTER-2 also met its primary endpoint. So this, again, is for grade 2 and grade 3 GEP-NET patients with Lutathera in the first line setting. And so we're going to have to see what the results of this is, and we're waiting for that. So, and that's all I have.
Any questions or comments?
In your practice, Dave, for a pancreatic neuroendocrine tumor, what do you choose, CAPE-10 versus PRRT?
Yeah, that's a very interesting question. I think there's several different considerations to think about here. One is in ESMO of last year, there was the Oculo random study. It was definitely not a study designed to demonstrate superiority, but it definitely was comparing sequencing of either do you do lutetium-177 first, followed by sunitinib, versus sunitinib first and lutetium-177. And what they demonstrated, even though it wasn't designed to demonstrate superiority, the curves in terms of PFS was very pronounced in terms of if you did lutetium-177 first. So there's some preliminary data suggesting that if you do PRRT earlier, it might be better. But I think there's still other questions, and that's compared to sunitinib. So we haven't compared to CAPE-10. We haven't compared to everolimus. So that's where the other studies are looking at. I also think that there are some concerns about how quickly Lutathera might actually work. So somebody who has, let's say, rapidly progressing disease, bulky disease, we know CAPE-10 has very high response rates in pancreatic neuroendocrine tumors. So that might be a situation where I might prefer to do CAPE-10. So.
And the safety regarding the myeloid neoplasms with beta versus alpha emitters, are there any differences? And in terms of sequencing of beta followed by alpha versus beta followed by beta, where do you think we are with this?
We're going to have to wait on the Action 1 study because definitely we're going to need much longer term follow-up.
You can't tell that from now. But when we talk about Lutathera producing response rate in NETTER-1, like 18%, my experience has been that you see better responses with pancreatic neuroendocrine.
That's correct. Response rates are usually more like 30%.
And I've seen some wonderful controls of disease and regressions, in pancreatic. But then again, pancreatic, they respond better to chemotherapy also.
Correct,
right?
exactly. So enroll into these trials. That's the take-home point. So,
All right, well, thank you very much,
Thank you.
David. Okay, last but not least. So now we have Dr. Kurian, who has transformed to be a hepatobiliary expert. And she's going to talk to us about the hepatobiliary cancers.
So Anthony asked me to help with these slides, and again, I'm very, very thankful to the leadership of the hepatobiliary cancers. A lot is going on in these diseases, and we are going to have a retreat tomorrow where we're going to talk about the next generation of trials. So far, in biliary tract cancer, based on TOPAZ-1, we know that GEM-CIS Durva is superior versus GEM-CIS, and we are very familiar with this data, and we're all using GEM-CIS durvalumab in first-line biliary tract cancers based on this study. We know that majority of patients across sites of biliary tract benefited, and irrespective of PD-L1 expression. Keynote 966 was also presented using pembrolizumab, GEM-CIS pembro versus GEM-CIS placebo, and the results were very, very similar in terms of benefit. And it seems that the patients with hepatitis B virus infection showed with on the right side with a red arrow had very similar outcomes irrespective of what arm of the study were included. And actually, patients with MSI high, which were very, very few, had basically been equally represented in both arms. The overall survival, very slight separation of the curves, but it's approximately 2 months with a hazard ratio of about 17% overall survival improvement with pembrolizumab. And let me see, what did I skip? I skipped something essential. So the investigator assessed and the central review were very, very similar in terms of overall response rates in these two studies, about 27, 28%, 29%. So, and the duration of response with pembrolizumab was almost 10 months in the Keynote 966. So one of the very much awaited studies, which Dr. Rashna Shroff from Arizona presented using the gemcitabine platinum nab-paclitaxel versus GEM-CIS. There was no immunotherapy in this study, SWOG 1815. About 441 patients were very, very rapidly accrued in this study. baseline characteristics, I'm not going to go over, but the overall survival, while numerically superior with a triplet chemotherapy, 14 months versus 12.7, the curves intersected. There was no overall benefit with this triplet chemotherapy. Progression-free survival, again, numerically larger, but no benefit statistically, 8.2 months with GemCis nab-paclitaxel versus 6.4 months. By disease site, we have looked at these results very carefully. It seems that the gallbladder carcinomas have a numerical overall survival advantage. There were, again, fewer patients with gallbladder cancer, so 17 months was overall survival with a triplet chemo versus 9 months with a doublet. And the progression-free survival similarly almost double for gallbladder cancers with the triplet chemotherapy versus the doublet. For the intrahepatic and extrahepatic cholangiocarcinomas, the results are very, very similar. In terms of the disease stage, the study allowed locally advanced as well as metastatic patients. We do see in the green and red curves, if you can distinguish them, we had about 77 patients locally advanced treated with a triplet and 40 patients treated with a doublet. There is definite benefit in terms of overall survival for the locally advanced patients with a triplet versus doublet, 19 versus about 14 months. The metastatic patients in purple and brown had no benefit in terms of overall survival. So again, these curves do show a little bit of separation for the locally advanced, which I think it's becoming relevant for the design of the future studies. In terms of response rates, numerically about 10% better with a triplet, 31% versus 22%. This was not significant, as well as a disease control rate, 77 versus 70%. Interestingly, the grade 3-4 treatment-related adverse events, when we look side by side, they were actually quite similar. The neutropenias, 37 versus 28, and so forth. So we don't see a tremendous uptake in the rates of grade 3-4 toxicities. I think maybe because we know how to manage side effects and provide supportive care, which was done during the study. The current second-line standard based on the ABC06 study, this was a study that used FOLFOX in second line, plus best supportive care versus best supportive care alone. We're very familiar with these results, about a month difference in median overall survival, with a hazard ratio, though, of about 30% improvement with using FOLFOX in second line. And also irinotecan-based chemotherapy. This was the Japanese NIFTY trial, or was it in Korea maybe? Using Naliri 5-FU versus 5-FU in second line. We have an overall survival of approximately 8.6 months with the Naliri versus 5.3 months with 5-FU alone. Very significant, with a hazard ratio of about 32% for survival, and also an improvement in PFS from 1.7 to 4.2 months. This study was tried to be reproduced in Germany, and we had seen this study presented at ESMO with no benefit in overall or progression-free survival in that setting. So in terms of NCTN trials, the Alliance has been conducting a second-line study using FOLFOX plus minus the MEK inhibitor binimetinib. I believe this study is in early stage for safety and tolerability, as well as preliminary overall survival. I'm not exactly sure whether this is ongoing or has completed survivorship, or maybe it's looking at interim futility. Next one, which is active and enrolling, maybe not doing quite as well, is actually a gallbladder cancer study where patients with incidentally found gallbladder cancer are offered surgery upfront versus several cycles of gemcitabine cisplatin followed by surgery, and everybody will be receiving more chemotherapy with gemcis. And we definitely need all the help we can to enroll into this study. ECOG ACRID 2205 is a very recently activated study which is looking at a combined morphology HCC cholangio, so patients that actually have a dual histology of HCC cholangiocarcinomas. These are actually rare cancers. About 0.5% to 14% of all primary liver cancers are HCC/cholangios, and it is considered a clonal disease. It has both characteristics of HCC and cholangiocarcinoma on imaging features. There are distinct molecular subtypes in this disease subgroup, and definitely patients have to have biopsy indicating both characteristics. Child-Pugh A, they have to have an EGD indicating no risk of GI bleeding in order to enroll, and no contraindication to immunotherapy. And the reason is because these patients will be receiving not just chemotherapy with gemcitabine and cisplatin, but there will be randomized to receive also atezo-bev in arm A versus gemcis in arm B. So basically we're combining treatment for biliary tract with HCC to study it in this group of patients. The study was recently redesigned to use gemcis atezo-bev versus gemcis atezo. So originally the control arm was just gemcis, and nowadays we have added atezolizumab to the control arm to make it more attractive to patients. So future SWOG plans, Dr. Richard Kim is proposing a very interesting study using Naliri 5-FU in second-line biliary tract cancers with KRAS mutations. These represent about 20-30% of our biliary tract cancers, and using onvansertib, which is a polo-like kinase inhibitor, which has shown preclinical synergism with irinotecan and particular benefit in KRAS-mutated cancers. And that's not just true in colon cancer, where a study has been conducted, but also in pancreatic cancer. So again, we have preclinical data supporting this study that polo-like kinase has been identified as conferring synthetic lethality when we inhibit it in patients, in actually cell lines with KRAS mutations. And this is the design of the study. This is going to be relatively small, 25 patients in each arm. Control group will receive liposomal irinotecan, 5-FU leucovorin, and the experimental arm will add the onvansertib, which is dosed 10 days in a row every 2 weeks, accruing patients with performance status 0 and up to 2, no prior therapy with irinotecan, and no concurrent FGFR2 gene alterations or IDH mutations due to existing targeted therapies for these subsets. Primary objective is progression-free survival. In HCC, we know that the current first-line standards are either the atezo-bev versus the STRIDE, durva-tremi, based on these IMbrave and Himalaya studies respectively. The 4-year updated overall survival has been recently presented at ESMO GI, and the curves remain beautifully separated. The median overall survival remains about 16 months versus 14 months with sorafenib. And at 48 months, 25% of patients treated with STRIDE are alive versus 15% with sorafenib. In the adjuvant setting, we have seen some good work being done, presented at AACR 2023, where patients who underwent surgery or ablation for HCC with high-risk features were randomized 1-to-1 to surveillance versus adjuvant 1 year of atezolizumab plus bevacizumab. The recurrence-free survival was the primary endpoint. Crossover was allowed. These are the patient's characteristics. The majority of the patients had hepatitis B as the underlying cause of their HCC. You can see the Barcelona stage classification. Majority were BCLC-A. Majority of patients were from Asia, approximately 71%. Baseline characteristics, most patients actually had surgery, about 90%, and only about 12% had ablation. There were a majority of patients, 60% had microvascular invasion as a high-risk feature, and 40% had poor tumor differentiation, grade 3 or 4. So again, high risk of relapse. These are the curves for relapse-free survival by independent review. We can observe that pretty much for the 1 year of the adjuvant therapy duration, the curves are separating beautifully, and then they slowly are coming together. So the hazard ratio was 0.7, so about a 30% improvement in relapse-free survival. But again, the question mark is, are we impacting the long-term survival for these patients? There had been overall survival is still immature, and it is, as you see, the curves are overlapping. In terms of safety, you can observe in the blue column that there had been significantly more grade 3-4 adverse events, 40%, with atezo-bev versus active surveillance, about 13%. So again, we don't think that adjuvant atezo-bev is a standard of care today. Definitely we need to do a little bit more work to determine how can we impact relapse-free survival and overall survival for early stage high-risk HCC. And research priorities for the SWOG hepatobiliary subcommittees are several. For biliary cancers, we are looking at neoadjuvant and perioperative approaches for high-risk intrahepatic cholangiocarcinomas, or for that matter, other cholangio-CAs. We know that there are differences between subgroups. Also for advanced disease, we cannot stop at Gem/Cis/Durva or Gem/Cis/Pembro. We do need to look at other novel agents, and definitely we need second-line studies for all comers. In HCC, again, the cancers have more than 50% risk of relapse most of the time. We need to look at neoadjuvant and perioperative approaches, as well as in the second-line setting and beyond, we need to address second-line options for our patients. Thank you so much.
Well, thank you.
I will try to take any questions.
That was excellent presentation. Single breath.
I'll give up on pancreas and take on HCC.
Okay. Any questions or comments? Gentry, do you want to make any comments? Or?
That's right, Gentry. Don't sleep.
Okay. No.
Thank you again so much.
Thank you.
And any of you that are here tomorrow, we have a retreat for hepatobiliary and gastroesophageal cancers, and we'd be very happy to see you.
Okay, well, enjoy your evening. Thank you very much for being with us today, and we'll see you. If we don't see you tomorrow, we'll see you in 6 months.
In Seattle. All right.
In Seattle.